Good evening, America. Guess what time it is? It is 5 o'clock on the Gulf Coast, which means it is time for Fertility with Fink and Friends. I am Fink. You are friends. And as always, I am in my favorite place to be this Tuesday evening. Every Tuesday at this time, 5 o'clock Central Time, which means 4 o'clock in the mountains, 3 o'clock on the West Coast, and 6 on the East. We get together here to talk about all those things that are important to us. And that's the business about making a family. That's the business about going through this fertility treatment and keeping sane while we're trying to do it. Great to see you all. Thanks so much for being here. As always, on Tuesday evening, we've got a bunch of different streams going on. We've got Facebook, a couple of different Facebooks. We've got LinkedIn. We've got Instagram and YouTube. I've got my Instagram right here, which is Randy Fink MD, and over here is New Life Fertilities. I'm a fertility gynecologist at New Life Fertility in Pensacola, Florida, where we also have offices in Mobile, Alabama, and in Panama City. I also work with the Missouri Center for Reproductive Medicine, MCRM, in the St. Louis area, Chesterfield, Missouri to be precise, and with their wonderful office also in Tulsa, Oklahoma. So if you're joining from any of those places, or even any place not part of those places, I am very happy to have you here tonight. A special shout out going to Brandis. Thank you for being number one to join over here on the Instagram side. Brandis is a wonderful, very talented nurse practitioner where I used to work, and it's an honor to have you on if you are indeed still on. You may have just turned on for a second and then disappeared. Alicia, howdy, and Katie. Hi, Miss Angela Sack. Nice to see you this evening. No, it's good to see you. Logan, the therapist. Hello. How are you from Missouri, I think, right? Thank you so much for being here this evening. We've got Sheila. We've got Sarah. Nice to see familiar faces as well as new faces here also. One of the things I'd like to talk about as people are just kind of coming to get here has to do with a question that I was asked through email. And by the way, if you have a question for me, please feel free to throw it up here on your social media platform. And if we can't get to it tonight, then we will. I'll certainly try to answer. If you'd like to email it to me, that's a good way to do that. And that's Ask Fertility with Fink at firstfertility.com. So I would say, by the way, New Life Fertility and MCRM are both part of the renowned First Fertility Network. And that is how we are brought to you this evening. But one of the questions that I got asked had to do with differences in people's protocols, and how is it that these protocols change when it comes to things like IVF? Why do we pick different medications, different doses for different people? And the answer to that is really quite simple. It's because every person is different. Every person differs, and there's a different physiologic situation that's going on with every stimulation that ultimately leads to how we're going to retrieve your eggs. Now, I have learned a lot over these years and now kind of do things very differently than I used to. Now I like to, I very commonly will use low dose or microdose HCG in the beginning, in the first several days of a stim cycle, really up to day 5. Start with some FSH, like your Follistim medication. Use a little bit of some HCG, like 100 units from days 1 to 5. And what that HCG does is that it feeds the follicles. It actually increases the number of receptors, of little antennas on those follicles that allow them to be stimulated by your FSH, by your Follistim. And what that hopefully results in is maybe being able to recruit a couple of extra eggs, and sometimes that can make all the difference in the world. And it also helps those follicles to be able to grow synchronously, that is to say, to grow together, so that they are all growing in one group as opposed to being all kinds of different sizes. And so that really can make a huge difference in people I've seen. And I've started to do that and really not adding the Menopur medication until at least cycle day 5, sometimes even a little bit later, depending on how well the follicles are growing and what the estrogen level looks like and so forth. So that's a little nuance that I have learned and really trying to institute it here. And it seems to be kind of making a big difference for people. And so someone asked me, well, gosh, could you start to critique people's cycles? And I said, well, I don't want to critique anyone's cycle because different doctors have different views of the way things are done and the way they should be done. And so it's not to be critical of anyone's clinical judgment, but I think what I may do is really start a YouTube page that will, there's already a bunch of these videos are on YouTube. But to be able to for people to say, okay, here was my cycle. And so then we can kind of pick it apart and start to talk about it so that everybody can learn a little something from other people's cycle. And if we put it in the kind of language and the kind of words that makes it so that we can all understand, then that improves every individual's understanding of what's going on, maybe in their very own IVF cycle, so that they might be a little better prepared to advocate for themselves. Does that sound like a good idea? I hope it does, because that's really my goal, to increase the kind of education that people have about their own cycles, about their own fertility, and particularly about the treatment that they're receiving. Because a lot of times you can really feel very lost and alone in this process, and depending on where you're getting care, sometimes it's hard to get answers. And so the more that you know about yourself and about what's going on with the body and with these medications, the more you can make intelligent choices for what you're doing. A special good evening to Mrs. Vince. Thank you for being here. And Pui, how are you? Thanks for being here. I still think about your sushi, my friend, and all that wonderful food that you brought us up at MCRM. And I hope that all is well. Please give my fond regards to your husband there. Logan, the therapist. Oh, Northwest Arkansas. Okay, so I was close. That is a beautiful part of the country there in sort of the Bentonville area where I have visited and lectured before. Beautiful. It was particularly beautiful in the autumn, which was when I was there last time. And boy, just such a beautiful world there. But very flattered that you are here with me tonight. Marlena asks, I am so curious, for those who suppress for endometriosis, what's the difference between choosing Lupron and choosing Orilissa? I've heard of using letrozole with the suppression too. Well, so that's a good question. So when you have endometriosis, we know that endometriosis can affect a number of different avenues in terms of fertility. It can affect the anatomy, right? So it can change. It can cause some scarring on the inside that results in maybe tubes being blocked or ovaries being in the wrong place. It can create a situation where there is endometriosis actually in the ovary, taking up some valuable real estate that your follicles might otherwise want to use in order to be able to grow, to help you have a baby. It can chemically change the signals that are going between brain and organs such that it can block your progesterone. Blocking progesterone is the mechanism by which endometriosis can prevent pregnancies from implanting inside the uterus. So when we find that to be the case, and by the way, the other thing that it does is that hormonally, it can also sensitize you to the effects of LH, luteinizing hormone, and even FSH. And so that does mean that I change my protocols for people who have endometriosis. because we know that endo is going to have an effect on the way your ovary responds, not just on the way your embryo implants. So we know that when you have endometriosis that's affecting that uterine lining, that we want to suppress it, because as long as it's blocking the effect of your progesterone, then that means that embryo may not want to stick inside of you. And so we can tell that by looking for a marker that's called BCL6. BCL6 is a marker that is associated with endometriosis and is tested for in a test known as Receptiva. And you can read about Receptiva at their website, and that's receptivadx.com, RECEPTIVA, receptivadx.com. You can read about it there. But what we know is that when that endometriosis marker is present in the endometrium, it can largely inhibit an embryo from being able to stick. And the example that I always give is that if you have a euploid or chromosomally normal embryo, that embryo can give you 65 to 70% probability of a pregnancy, unless that BCL6 marker is positive. And if it's positive, it can change that 65 to 70% number all the way down to less than 10%. And that's very meaningful, unless we suppress it, unless we turn off the hormonal supply to that endometriosis by using a medication, either Lupron or Alyssa, or there's another one that's called Myfembree. Those three things will shut down endometriosis temporarily, and 60 days is all we think we need. 60 days of suppression is sufficient to turn off that BCL6 marker so that your ability to implant a pregnancy returns really to what it would have been if you didn't have endometriosis at all. So that's the rationale for suppressing. And the question was, Marlena's question was, well, what's the difference? So Lupron, Depo-Lupron is a long-acting version of the Lupron drug. What Lupron does, without getting too complicated, is basically tells the brain, shut off the hormone supply. Stop stimulating the ovaries, shut off the hormone supply, and it basically puts you into a temporary menopause. Now, Orilissa is a newer version that is delivered in the form of a pill, and that pill is often better tolerated than the shot, because you can imagine menopause doesn't feel really great. You can get hot flashes, vaginal dryness, you can get leg cramps, you can get sleep and mood disturbances. It's something that it doesn't feel great. You do what you have to do if you need to do it, but Orilissa is taken instead of one shot that lasts you a month. There's also a version of Depo-Lupron that can last for 3 months. But when we're suppressing endometriosis for fertility, what we know is we really only need that for 60 days. So if you're suppressing for 90 days, you're probably getting an extra 30 days of suppression that, again, doesn't feel good, that probably does not, or at least by the data, does not seem to benefit you anymore. So I don't recommend that one. I recommend the once monthly Lupron shot, which shuts everything down, or Orilissa, which is a pill that's usually for this purpose taken twice a day. It can be taken once a day, but most recommendations when using it to suppress for fertility purpose recommend 200 milligrams twice a day is the correct dose. That's the dose that you would use if you knew that you had endometriosis and you also had pain with intercourse. That is the recommended dose, 200 milligrams twice daily. The other medication, Myfembree, is taken only once daily, so it has some advantage there. Myfembree also has some add-back hormone therapy. So it mitigates, it turns down some of the side effects associated with shutting down your hormones. Oralissa as well is a little bit more selective in terms of how it shuts the hormones down. So it's tolerated a little bit better than the Lupron shot. In fact, the tolerance or the kinds of things that people complain about or the reasons that people might discontinue using the medication with Oralissa really are not substantially different than the same thing we would see for people who are using birth control pills. And birth control pills are really amongst, everybody doesn't love birth control pills, but they're amongst the best, the highest prescribed medication in the history of medical science. And we know more about birth control pills than we do about most other types of medications. So it is, it's a well-tolerated thing. Why would you add letrozole? Well, the whole point of using this suppression is to turn off your estrogen, because it's the estrogen that feeds the endometriosis, and endometriosis is what's causing that BCL6 marker. So what we want to do is suppress the estrogen. Lupron, Oralissa, Myfembree are all telling the brain to tell the ovaries to stop making estrogen. But we also make estrogen from other places in our body, and we make that estrogen in our fat cells. And we all have fat cells. It is not a judgment against anyone, even those people who are very, very thin still have fat cells in their bodies. And those fat cells convert testosterone, which everyone has in their bodies, women and men. It converts that testosterone into estrogen. So when you add letrozole to even Lupron suppression, then what you're doing is that you're turning off the estrogen production, not only the brain telling the ovaries, but also telling the fat cells in the body, stop making estrogen from testosterone. And the evidence shows that there may be a little bit better of an outcome when you do that, but the side effects may be a little bit higher. So it's kind of a balance thing. Is it worth the side effect, the difference in side effects, for a very marginal increase in success rate? And it really depends. It varies individual by individual. That's kind of the way I think about it. But that's a great question there, friend. And so I appreciate you asking it, because it hits to some of the nuances of how and why we do that suppression. Hello to Sharmila and Baby. Nice to see you guys there this evening. And the wonderful Bama Gal, my mom and dad there in Mobile, Alabama, not too far from me right now. Hello, and thank you for being here, for figuring out how to get on your iPad or wherever you happen to be watching it this evening. Let's see here. Who else? Hi, Midgie. Good to see you there. We've got my friend Noodles, and we've got Mohai. And again, forgive me because I think I always mispronounce your name. I don't know if it's Mohai or Mohi. Amal. I think you told me was your first name. Hello, Amal. Good to see you. What's a good inflammatory or anti-inflammatory diet for fertility? That too is a really loaded question. And it's a question that I get all the time. What diet should I be on? And maybe you've heard me say this before, but there is no one diet that has consistently been associated with the best in fertility related outcomes. There is a lot of noise in the fertility space about what diet you're supposed to be on. People talk about keto. People talk about carnivore. People talk about, oh, no, you should be on a vegan diet. Oh, no, you should be on a dairy-free diet. People say, oh, gosh, yeah, you should be on a Mediterranean diet. Well, the truth is, all those things may really have some benefit. Keto is said to be very anti-inflammatory, and that's a good thing. Mediterranean diet is really kind of my choice because keto can be hard. And some might argue and say hard things, bring about good things. And so you got to make some sacrifice. And I would say, yes, that's true. If you could show me data that said it's the best, because if we could say it's the best unequivocally, then no doubt everybody should be doing keto. It's a sensible diet. That's what I would want you to be on. The American Heart Association says that the best anti-inflammatory diet is the Mediterranean diet. So ultimately, what all of these diets agree on is that carbs are pro-inflammatory, that carbs are really the enemy. And so the more you eat in terms of carbohydrates, the more inflamed your world is going to be. So to the extent that you can decrease the carbs that you consume, you will do better for yourself in really every walk of life and every aspect as far as your health goes, but that includes fertility. So whether that's keto, whether that's carnivore, whether that's Mediterranean, whatever works for you is what I think is the best, as long as you can limit your carbs. Now, I do not think that you can cut carbs entirely out of your life. That is unreasonable. That is unsustainable. And I strongly advise against trying to do that. But you can limit those carbs. You can be more careful with what's going in your mouth. And honestly, I think Mediterranean is very sensible. It's not a hard diet to keep. And so that's really kind of my number one recommendation. Keto is a good thing to do. People do lose weight with keto. The problem is that it may just kind of be, hard to sustain. A special shout out this evening to Zenny in Miami, who always says that I never say hello to her, and I say hello to her every single time. Hello, Zenny in Miami. Thank you for being here this evening. And like I said last week, you brighten up the room just because you're here. So thank you for that. A Baria 1015 says, any suggestions for helping egg quality? I have a daughter through IVF, thanks to New Life Fertility in 2020. Egg quality has seemed to be my major issue. Well, so the kind of latest and greatest thing in egg quality, well, there's really two things. First is, there is an evidence-based supplement protocol for what can a handful of vitamins do to help us get pregnant. And I am happy to give you that. I keep it in a little book. I wrote an ebook about that. That's called The Vitamin Victory. Very easy to read, low price. It's $7. You can get that on my Instagram. That's Randy Fink MD. And even included with that is a link for a discount that will save you about $30 or $35 on the whole bunch of those supplements if you choose to take them all. So egg quality is probably one of the more important features in IVF. But the latest and greatest thing that we have, and that I've talked about before here, is a medication that's called sirolimus, also known as rapamycin. I'm using rapamycin or sirolimus as my first line in treatment for egg quality. And what sirolimus, rapamycin, does is that it's actually a medication that's used for folks who have had organ transplants and need an anti-rejection medication. And that's kind of what it does. It works in a particular pathway that affects the way our body starts to repair our age-damaged DNA. And so one of the theories is that as we get more and more and more and more working on trying to repair our DNA, our system goes faster and faster and faster and faster and faster. And from yourself, the faster you go with something, the more likely you may be to make a mistake on it. And the same thing really happens at the cellular level. So what this medication does, sirolimus, is that it sort of taps the brakes on that process. It slows things down, which allows the body to be more precise in its DNA repair. And some studies from 2025 looked at low dose, that's 1 milligram once a day, that's one pill once a day for really anywhere from 21 to 30 days. So I usually start at 21 days before a stim start and keep doing it no longer than after the day before retrieval is usually when I stop it. And that seems to have very good effect on egg quality. The study showed that it increased the number of better eggs. the number of higher quality embryos. And so they know that higher doses can sometimes be associated with doing the wrong thing, but it's the low dose for a short window seems to make a lot of sense. The other good thing about sirolimus abaria is that it's dirt cheap. It's very inexpensive compared to omnitrope, or growth hormone is what we always used to use. But the problem is there's just no good data on growth hormone that says that it really works. It works for some people. We all have experience in doing cycles in people once we've added omnitrope that seem to make a huge difference by putting growth hormone in. But in the general population, it just really hasn't been shown to make a huge difference, and it is incredibly expensive. So that's the reason. Sirolimus is really very well tolerated in people. Some people don't want to take it. They'd rather use omnitrope. That's fine with me, but that's kind of the latest news I have in terms of doing things for egg quality, and I hope that helps. Brittany is here. Hi, Brittany. Thanks for being here on the Facebook side. Thank you, she says, for doing my retrieval. It's my pleasure. I've been wondering on PCOS, is there any way to get cycles to return? I have decreased my insulin level from 17 to 8 with metformin. That's excellent. I did get Hashimoto's at some point, and I struggle with high testosterone. So the answer to that question, Brittany, is possibly. Yes, possibly. So first thing, you've done great things by decreasing that insulin level, thus which means that you decreased your insulin resistance. And insulin resistance is really the culprit there. The way I think about PCOS, about polycystic ovarian syndrome, is that it's a three-legged stool. The stool that you sit on, right? It has three legs to it. One of those legs is the ovaries, and what happens with ovulating, releasing an egg in a timely fashion. You got a lot of eggs that are hanging out there, and they fight with one another. And so as they're fighting, they may not be able to figure out which is the one that's supposed to get released. And when that happens, you also get a bunch of downstream hormone problems, and so it can create a mess there in the ovaries. The second leg of that stool is insulin resistance. And the third leg of the stool is what happens with your testosterone. So classically, polycystic ovarian syndrome happens when there is some defect in each of those three pathways. But what we know from this three-legged stool is that if you can affect something going on in one leg of that stool, then you can affect all three legs. So that's really the rationale for metformin. Metformin, or if you want to do that in supplement form, it is myo-inositol. Myo-inositol really does the same thing as metformin. If you want to do that, you can. That will affect the insulin resistance for sure, the testosterone to a milder degree, and often when you fix or address that insulin resistance, you really can do great things by making the ovaries more responsive. It sensitizes to the ovaries to the natural hormones, which may get you to start ovulating and having a regular period. So sounds like you're on the metformin, and that is a good start. The second thing they say specifically is weight loss. And I am not a stickler for weight. I don't get caught up in weight. We're happy to talk about weight sometimes if we need to. In the state of Florida, actually, you have to have a BMI, a body mass index, that's less than 40 in order to be able to have anesthesia in an office setting, so to be able to do IVF. So that's a thing, and that's the only time that weight really, becomes really important to me, worth the conversation. But they say that if you can lose anywhere between 5 and 10% of your body weight, then that is likely to have such a significant effect on your PCOS that you'll probably return to normal cycles. So what does that mean? Well, it means if you are 200 pounds, if you are able to lose 15 to 20 pounds, then you probably will get a lot closer to having those regular cycles. So those would be the two kinds of things that I think of there. Let's see. Noodles asks me, estrogen resistance. You are estrogen resistant after Orilissa suppression. You had a canceled FET due to the lining not being thick enough. You restarted with the Del estrogen, but after 1 week, still not growing. Interesting. Well, what I would do in that case, Noodles, I would probably use a combination of things. I'd probably use the Del estrogen, which is injectable. I would do it along with oral estrogen or a patch. Now, I think you probably did oral before. I might do the patch and the shot together. I would consider doing some intrauterine PRP, but if that doesn't cut it right away, I would say just take a break. I'd say take 4 weeks off, maybe even 2 months off, let your body return to cycle, and then let's see what's going on. Because that suppression medication really should not still be in your body. The reason that Orilissa works the way it does, that you have to take it on a daily basis, is that it has a pretty short half-life. Meaning to say, if you don't take it every day, you don't get an average serum level, and it will just kind of shut off and stop working. So my advice would be, I'd also want to see some things with your hormone levels there, Noodles, because I wonder, what else may be going on there. But just from the 10,000-foot view, that's kind of where I think about it. Let's see here. Sharmila says, I used to take baby aspirin throughout my pregnancy, but now I could see some blood clots on my legs and thighs. Should I continue baby aspirin? Well, I think the answer there is, so Sharmila, I'm not sure if you're last I heard you were breastfeeding. I think you might have told me that you stopped. So Sharmila went on to have a baby, which is a wonderful, happy success story. The baby aspirin, there really aren't a lot of studies that show that it makes a difference in most people. The kinds of things that you typically see in your legs and thighs are what we call superficial thrombophlebitis, or basically varicose veins. And that stuff can happen really irrespective of, that's really probably mostly from the pregnancy itself. That also happens just as a result of aging. And so it is unlikely that baby aspirin is going to prevent that from happening in the superficial veins. The thing that we get more worried about is what's happening in the deep veins, because a deep venous thrombosis, that's a blood clot in one of the deep veins in the leg, that can be a problem, because that little blood clot can break off and end up going into the lungs, and that's called a pulmonary embolism, and that's a very dangerous thing. So those superficial clots are more an annoyance. They are they can be painful. They can be an aesthetic problem, but typically they are not dangerous. So if you're trying to get pregnant again, is it harmful for you to be on baby aspirin? Probably not. But I do want to point out here, again, not good evidence that for the general population that a baby aspirin is helpful to people who are trying to get pregnant. And I do want to say that the new primary care guidelines, which used to say that anybody who may be at an increased risk of cardiovascular events in their lives should be on a baby aspirin. And that's changed now, because they consider the possibilities of bleeding or of stomach ulcers or some, other kinds of things that can come from prolonged use of baby aspirin to be probably more risky than it is helpful in preventing those things from happening. So our thoughts about baby aspirin have really changed over the years very significantly, from previously suggesting that 80% of the population should be on baby aspirin for cardiovascular preventative effects, to now saying, well, really, you have to be in real specific scenarios, like if you already had a heart attack or some cardiac event, then being on a baby aspirin may help and be preventative. Hey, look at what just happened here. We're going to go over to Facebook here to get your questions in just a moment, but I bypassed 6 minutes late here for the 5:30 fuzzies. with Fink. And that is the time that we all get to stand together as one community and send out the good vibes to everybody in our world who needs it at this moment. This fertility business, as I am fond of saying at the end of my program, is not the book of your life. It's just a chapter. But this chapter can be a doggone hard one to read. It can be something that creates a great deal of angst. It creates a great deal of feelings of loneliness, of fear. Oftentimes, trauma results out of fertility treatment. We can get a little PTSD, or at least post-traumatic stress, from having gone through fertility treatments. But it's not just fertility. It's not just the unknown of what happens, or that desire to have that family so badly that you can taste it in your mouth, or that it's just out of reach of your fingertips, but you're trying so hard to get there. It's not just fertility. It's about relationships. It's about family. It's about friends. It's about work. It's about school. It's about any of those places that make us feel alone. Well, I'm here to tell you tonight, as the 5:30 Fuzzies with Fink, you're not alone. This group of people here who join my particular podcast are such a wonderful group of folks that I think any one of you would bend over backwards and almost literally give the shirt off your back to someone in need who is going through something that maybe you'd been through yourself. And maybe it's time that we look to those people and say, you know what? We can do this. We can get through this, and we'll get through it together. You are not alone. So now together, let's send out all those good, wonderful, happy vibes. Let's break the internet with kindness tonight by telling everyone out there that we're all in this together and you are not alone. We're all here to help each other. And that, my friends, is the 5:30 Fuzzies with Fink, or in this case, the 5:36 Fuzzies with Fink. So if this is your first time experiencing that, please join me next week. Do it again, even if it's just for a couple of minutes, right at half past the hour, so that as many people as we can get here at that particular time. Tell your friends, because really I want to break the internet with kindness. It would be really something meaningful to know that every single one of us made a difference in somebody's life tonight. So if not tonight, how about next week? Please join me for that, won't you? Okay, let's jump over to Facebook. I've got some questions here coming from Carly. Hi, Carly. Good evening. What would you say to one whose levels seem to be normal, but PMS symptoms have worsened in, say, the last year? My husband and I have been trying for almost 6 years with no pregnancies. There's some male factor infertility, but I can't help to think that something is off in my body. I've done all the testing on my end and everything seems normal, but normal doesn't seem to feel right. You know, Carly, that is a great question. And you bring up a much bigger issue as it pertains to PMS. And that is, what the hell is PMS? Well, PMS is that pervasive feeling of, well, those symptoms that may be associated with some physical things and may be associated with some mood things that happen every single cycle. They typically start to happen from the time, and by cycle, I mean every single month that you ovulate. They typically start to happen from the time that you release your egg. So basically from mid-cycle, from ovulation, and that lasts typically getting a little worse and a little worse and a little worse until ultimately you get your period. And typically you get your period and those symptoms go away. That's how you describe PMS. But what's really causing it? And the answer to that is we don't really know for sure. There are some thoughts that it may have to do with inadequate progesterone in the luteal phase. So I have treated that with progesterone creams before with very good effect. But the truth of the matter is that it's not something that you can diagnose in a lab test. And so you tell me that your levels have all been normal, which I think is a great thing, but I wouldn't necessarily expect anything different. I don't know how to test someone for PMS because most of the time when somebody says, I don't feel well, I want to test my hormones, I say, okay, well, but those numbers don't correlate necessarily with how we feel. It's not that we say, oh, looky here, your estrogen level is 1.2 high. So if we just flick that switch off, suddenly you're going to feel better. Oh, it must, I'm having problems with my weight. It must be my hormones. And we say, oh gosh, look at that. You don't have enough progesterone. If I just give you more progesterone, that weight's going to fall off of you like it was water dripping off a duck. Doesn't work that way. The same is really very, very true with PMS. And that is that no lab test correlates with what's happening at the cellular level, nor has there been any specific lab test that's associated with that constellation of symptoms that is what we know of as PMS. So it can be treated in the brain. For example, we can treat that with cyclic SSRIs or antidepressants, which work in a completely different manner than SSRIs would work for someone who is facing issues with, let's say, depression or anxiety. If you have depression or anxiety and you take something like Prozac or Lexapro, those medications really honestly need probably at least 6 to 8 weeks before they build up enough in your body that they're going to make a difference in the brain. When used for PMS, it can be used really just from the time of ovulation till the time you get your period. So 14 days out of the month, you can use it, and miraculously, people start to feel better, which means the mechanism is completely different than what we know of when treating depression and anxiety. So, Carly, I think you're right. You know better than anybody that something is off in your body with your hormones. But the problem is when we're looking at hormone levels and trying to correct these things, very difficult to pin, pin a nail or take a thumbtack and put it into, some specific abnormal lab test. But again, I think that, progesterone is an issue that's associated with pregnancy, and progesterone levels coming from your corpus luteum after you release an egg. And treating with progesterone can sometimes be very helpful with treating PMS just in the luteal phase for 10 to 12 days with a topical progesterone cream just to increase your progesterone a little bit. I've had very good success with that, and some people actually do get pregnant with that as well. So certainly food for thought, something to think about. But Carly, that's a great question, and I appreciate you asking. Let's see. Carly also says, I've lost about 30 pounds naturally in a year and a half, thinking it would help, but to no avail. The semen analysis isn't ideal, but they're not the absolute worst. Well, so, there are some secrets to the semen analysis that may suggest that even though numbers look good, I look for things like DNA fragmentation or what's called a forward progression score, because that may tell us how well that sperm is really going to function in the body, being able to knock on the door of an egg in order to fertilize it. So there may be a lot more to that, Carly, than meets the eye. A special hello this evening to Jennifer. Hi, Jennifer. Nice to see you. You have your FET scheduled for tomorrow. When do I stop taking the 6 supplements? I would say after you get a positive pregnancy test. So those 6 supplements for embryo transfer are your prenatal vitamin and your omega-3 or your fish oil. Those 2 things you will continue when you're pregnant. Those are the only 2 supplements you need to continue when you're pregnant, and that's your prenatal vitamin and your fish oil. The other 4 things there, vitamin D, vitamin E, CoQ10, and L-arginine. I would say take all of those, Jennifer, until you get your positive pregnancy test. and then you can stop and just stay with the fish oil and the omega-3. My friend, my fingers are crossed for you. Come tomorrow, big day tomorrow for that embryo transfer, and all the luck in the world is going from us to you, my friend. Sincerely. Taylor's here tonight as well, who says, I have PCOS. My partner has male factor. We recently did a retrieval cycle in January. We did ICSI and had all the embryos arrest in the day 4 to 6 window. In your opinion, what do you think the reasoning for the poor outcome would be? Is it due to egg quality from PCOS? Well, that certainly may be part of it, because one of the things that happens in PCOS when we stimulate your ovaries, if you're not really careful, you end up making quantity over quality. So you may retrieve, 30 or 40 eggs. Gosh, where I used to work, I had someone, the most I've ever retrieved 120 eggs from someone. And that certainly doesn't feel good on your ovaries, right? Because ovaries that are normally the size of walnuts become the size of, at least coconuts, and sometimes even, melons. Not a good feeling to have in your pelvis, for sure. But the ovaries tend to be very sensitive to the medication. And so they like to respond. They like to make those eggs for you. But those eggs are quantity over quality. So really what you have to do is you have to dial back those protocols. You have to lower down the stimulation and maybe do things a little bit differently so that you're getting a nice cohort of normal eggs that aren't hyperstimulated or created in a high estrogen environment. That would be the first thing that I would think. The second thing I would have to wonder about, so you're talking about a blast rate, and so that means that, well, the eggs were okay enough to fertilize, and they were okay enough to grow to kind of day 3, but that's where they stalled. And so there may be some different things in what happens with your LH levels, Taylor, at the beginning of your cycle. So I would handle that one a little differently as well, because if you have PCOS, your LH levels are already very high. And the last thing I'd think about is, well, is there some DNA fragmentation that is allowing an egg to fertilize, but is preventing it from continuing to grow? So the one easy trick that I recommend for every male who is providing sperm for IVF is to increase the frequency with which he ejaculates. Tough orders, right? Increase the frequency of ejaculation. I had a little Instagram post about that. I think it was just earlier in this week. So we know that when you're doing a semen analysis, we want you to refrain from ejaculating for 3 days, right? Because we want to maximize sperm count so we can count and see how many sperm are actually there. Well, when you're doing IVF, if you increase the frequency of ejaculation, your sperm count does go down, but the sperm quality goes up. And when it comes to IVF, you don't need millions and millions of sperm. We only need one individual sperm for each egg. So certainly, Taylor, if you were going to do it again, just looking at it from above here, I'm saying I would suggest dialing down your stimulation, decreasing the amount of LH you get, either Menopur or HCG LH in the beginning of the cycle, or handling that LH differently, and increasing the frequency of ejaculation. So without knowing any other specifics, that's kind of my gestalt over where I think we are with you, Taylor. I sure hope that that is helpful for you. Let's see. And Taylor says, I had 36 eggs retrieved and 27 fertilized. So yeah, there's no doubt about it. If you're fertilizing 27 eggs, then that's quantity over quality. I can think of really only 1 or 2 cases of people who did, in fact, hyper respond, made a whole lot of eggs, but they hyper responded on really very low dose stimulation that ended up with an a lot of blastocysts, like 25, 30 blasts. And I would say you don't need 25 or 30 blasts unless you intend to donate them to somebody. What are you going to do with that many embryos? By the way, folks do ask the question, do you guys, will you consult for people, in other clinics? And the answer is, I am always happy to give an opinion. You can reach me either through MCRM, that's the Missouri Center for Reproductive Medicine, where I see patients remotely half a day a week on Friday afternoons, or at New Life Fertility. And the website for that is fertilityleaders.com, fertilityleaders.com. And happy to consult with you, happy to give an opinion, even if you're seeking therapy someplace else. Oh, let's see. Hey, Bailey, if you're still on, that was a while ago. Kathleen has joined, one of our wonderful, wonderful nurses here at New Life Fertility, a wonderful, just great personality, someone who also really brightens up the room just from being around. Has a set of twins. Oh, yeah, she's a busy lady. But we love you, Kathleen. Thank you for being here. Hi, Stephanie Sierra. Thank you for being here. Frida, good evening to you. Nessa says, what if your insurance does not cover the medication? Well, you asked that, and I'm not sure which medication we were talking about at the time. I think we talked a little bit about, sirolimus, we talked about Omnitrope. Sirolimus, even if insurance doesn't cover it, it costs about $40 for a month's supply. Omnitrope is most commonly not covered by insurance for IVF because that's an off-label use. And it can cost, the fertility pharmacies have it for about $700 for a vial. Whereas if you try to go to Walgreens or CVS or one of those places for it, it may cost you $5,000 for a vial, which is an outrage. Please don't ever pay that much for that medication. But Nessa, there are many situations in the fertility world where insurance isn't going to cover medication or treatment, because insurance is trying to say that your ability or your desire to have a family is not a medical concern, it is an elective concern. Personally, I happen to disagree with that, but that's the way many insurances are structured. And so if something is coded as fertility or being used for fertility, they just simply won't cover it. So, in my world, I'm very used to folks having to pay out of pocket, for instance, for IVF, which, it is also, something very, very expensive. And those medications are very expensive too. So yeah, that's an unfortunate thing. Katie asks, can you take myo-inositol while breastfeeding? I currently have one IVF baby. I believe the answer to that is yes. I don't see any contraindication to doing that. You could certainly, yes, in fact, I will say unequivocally, yes, you can take myo-inositol. Now, sometimes you take a supplement or even a medication that's approved while breastfeeding, and you start to find that your baby starts not tolerating it. You may find that your baby, starts to get, some reflux, gets to be some colicky based on your, some medicine or some food that you keep eating. Maybe you're craving spinach and you keep eating spinach, and then your spinach, the baby starts getting colicky, so there's always a possibility to just watch for the downstream effect. But from a safety standpoint, I would say yes, I think that's okay. Holiday Homemaker, good evening. And the sweet and wonderful Angelina Foxy from the great state of Minnesota. Thank you, Mrs. Fox, Practitioner Fox. Thank you for being here this evening. And you've got some exciting times coming up because you will be vacationing down here on the beautiful Gulf Coast, and we are excited to welcome you. I can't wait to see you down in this part of the world. Looks like Malanid, I believe, is it okay to travel on an airplane 10 days after an embryo transfer? Absolutely, it is. So, when you hope that you are pregnant, I always recommend you drink a little extra fluid, especially when you're on the airplane, because it's going to keep you getting up and probably emptying your bladder more than you might otherwise be. And that moving around is probably a good thing. So yes, it is. People will come to us for an embryo transfer, and then the very next day, or sometimes even that afternoon, go to head back home and take an airplane. So yes, there is nothing inherently dangerous about the altitude that causes problems with embryo transfer. So yep, it is okay. Hey, Marco, nice to see you this evening. Jess, hi, Jess. It's great to see you. So Jess is also a wonderful and fantastic nurse practitioner who lives in the Dothan area, and I believe Enterprise, Alabama, as well as where she is working between Dothan and Enterprise. Used to work with me at New Life Fertility here, an extremely talented nurse midwife and provider. And thank you so much, Jess, for being here, if indeed you are still here. See, so what happens is people join and I see their names and I'm looking at other feeds here and answering questions and stuff. And then by the time I get over and want to say hello, oftentimes they've logged off. They only logged in to say hi, or they watched for a few minutes and then had to move on. So if I didn't get to say hi while you're watching, I really do appreciate even that you were here for a few minutes. And that goes for you, Nancy Gomez Bernard in Miami. It is great to see you here, and you are truly, truly missed. Let's see. We talked about traveling. Nessa was asking about the medication for the better egg quality. Yeah. So as I said, that sirolimus, if not covered by insurance, and usually it would be, look at GoodRx, because I think it's like $38 for that month of medication. Certainly a far cry, orders of magnitude difference than what you'll see from the Omnitrope. Let's see. They will not cover if I use the egg quality medication. So again, not sure which one you're talking about there. Pensacola Wellness, good evening to you. And Angela says yes. And actually you're coming on vacation to the Gulf Coast and bringing the little bundle of joy that I got to help you bring into the world. Love that. Oh my gosh, I can't believe Kaylin is here for even a moment. If she's there, I am seeing all kinds of very special people tonight. And Cowgirl, you, my friend, are certainly missed, as you know, but the problem is you just don't care. You don't care that you're missed. You like people to miss you, don't you? I know the way you work. Yeah, I know. And the kids, and please send my love to the kids. I'm missing their drawings. I don't have any drawings on my wall from them. So if anybody wants to send me one, just saying, happy to put it up on the wall, and I'll even send a picture of it. So take that back home, would ya? Mrs. Sirach, my favorite doctor. Oh, tell me who it is. I'll find out for you. I'll see if I can get him. Thank you. I appreciate you saying so. Hello, the Daverly. Melinda said, what is the name you said for the medication that's more affordable than Omnitrope? And that one is Sirolimus, Sirolimus, the brand name of which is called rapamycin. Well, we are approaching the top of the hour here, which means it's time for us to say goodbye for this week. It has been, oh, Mrs. Sirach's Vanessa Jerome. Wow, I can't believe it. Well, you. See, I got distracted. See what you did to me there? You distracted me. It's great to see you. Instagram me there, would you? Folks, this is a great place to be every Tuesday evening at 5 o'clock Central Time, where I invite you to join Fertility with Fink and Friends, because I am Fink and you are most certainly friends. And this is the best time of the week for us all to get together and just talk about what's important. So you know what, as I said before, the fertility thing is not the hormone thing, whatever it may be, is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite it together. Every step forward with kindness, not enough kindness in the world. Every step forward with love, and every step forward with hope, because tomorrow is a new day and it is full of all new adventures. So until next week, from Pensacola, I'm Dr. Randy Fink. Thanks so much for being here, and good night.